right, so we'll go ahead and get started. Principles of mechanical ventilation. I just want to start with telling you the application of mechanical ventilation. So you work in different areas of the hospital, whether it's in the emergency department, adult ICU, pediatric ICU, even with the newborn babies, they come out and their lungs aren't fully developed, they need a ventilator. So mechanical ventilation is needed throughout the hospital. And again, you guys become the experts at mechanical ventilation. As far as people needing a ventilator, what is the primary function of a ventilator? So I have some notes for you to write down before I start with the PowerPoint. So the primary function of a ventilator, and there's two. The first one is to ventilate. First one is to ventilate. And it's to get air in and out of the lungs. Due to muscle fatigue, or CNS depression, central nervous system depression. So that's the first function of a ventilator, is to get air in and out of the lungs due to muscle fatigue or CNS depression. So if somebody can no longer move enough air in and out of their lungs, then we're going to do it for them. And then the second function is to oxygenate. If something's going on, remember if EQ mismatch becomes too great or there's shunting going on, no matter how much oxygen we apply to the patient, they're not responding. And at that point, they would need to be intubated and put on a ventilator. So ventilation and oxygenation are the two functions of a ventilator. Okay, one more thing I want you to write before I put on the PowerPoint. What is respiratory failure? Patient has respiratory failure, they need to be placed on a ventilator. Well, respiratory failure is the inability to maintain adequate oxygen uptake and carbon dioxide clearance. So inability to maintain adequate oxygen uptake and carbon dioxide clearance. So when we breathe in, we want to get oxygen into our body, and when we exhale, we want to blow out the waste product, carbon dioxide. All right, with breathing with a ventilator is not what's normal physiologically for our bodies. So when we breathe normally, we create a negative pressure in our lungs. When we create that negative pressure, that's what pulls air into our lungs. Somebody who's not breathing or not breathing well enough, and we have to breathe for them, we push air into the lungs. So we use a positive pressure, and we push the air into the lungs. And that's not physiologically normal. So we always have to keep an eye on how much pressure builds up in the lungs, because yes, we're trying to save a person's life, but too much pressure and we're going to damage their lungs for the rest of their lives. So yes, we need positive pressure to ventilate, but we have to keep in mind that that positive pressure can also cause damage. So here it says, spontaneous breaths are negative pressure, but machine-delivered breaths are positive pressure. And when you look at that on a graph, what you show is when you're at atmospheric pressure, we're standing in the room, we call that 0. When we breathe in, there's negative pressure generated inside the lungs, and that's what pulls air in. And then when the rib cage and the diaphragm go back to their resting position, that pushes on the lungs and creates a little bit of positive pressure in the lungs, and then that's what makes the air leave the lungs. So it shows the line above a little bit positive because on exhalation, the air in the lungs is a little bit positive from the diaphragm and the rib cage pushing on the lungs. In the pleural space, we know that it's always kept negative because that's what pulls and holds the lungs open at all times. And now look at somebody that we put on a ventilator. And now we're going to push the air into their lungs. So you see this line, this red line go up because a lot more pressure is generated when we're pushing air into somebody's lungs. It even makes the pleural pressure less negative because we're pushing air into the lungs. All right, so if I were to show you this graph and ask you which one is spontaneous breathing and which one is positive pressure breathing, would you be able to identify each one? Okay. All right, at the bottom it says identify the pressures in the pleural space. So we're looking for PL. So what is the pressure in the pleural space with spontaneous breathing? Negative 10? Do you see how you have to look on the x-axis, y-axis, I'm sorry, and it's minus 10. And what is it for a positive pressure breath? The pressure in the pleural space. Yeah, approaches 0. Identify the pressure in the alveoli. So it's right here. It's pointing to spontaneous first. Yeah, pretty much 0. It's a little bit negative during inspiration, a little bit positive during exhalation, and then 0 at the end of exhalation. All right, what is the alveolar pressure when we're pushing air into the lungs with a ventilator? Starts at 0, but where does it go? Yeah, it shows it going up to 10 centimeters of water. All right, so that's just showing you the difference between breathing spontaneously, which is normal, and then being put on a ventilator, and how now you've got a change in pressure inside the thorax. Let's learn the abbreviations of different lung pressures. So pressure in the pleural space is a P with a subscript of capital L. And that almost looks like the beginning of the word of plural. So that one is easy to remember. Pressure in the alveoli, capital A, is alveolar pressure. And you've learned that when you were learning your alveolar air equation. P, capital A, is talking about the alveoli. So that one should be easy to remember. Pressure at the mouth and the airway opening, AWO. Airway opening, I guess. Sometimes you see the W when you're reading in the textbook, and sometimes they don't have the W. So if it's AO or AWO, it's what the pressure is at the mouth.
So it can be AO also?
AO or AWO, yes. And then pressure at the surface of the body, or atmospheric pressure, is capital B, capital S, body surface. And why do we need to know these abbreviations? So when you're reading in the textbook and we're talking about pressure in the atmosphere, you want to know that the abbreviation would be PBS. If we're talking about pressure when we're pushing air into the lungs and we're measuring it at the endotube, that would be airway opening. There's a way on the ventilator to find out what alveolar pressures are, and then that would be P capital A. So you're going to be applying it as we go along. And then there's pressure gradients, or the difference in two pressures. And there's two of those to remember. Probably the most important one is the trans airway pressure. All right, so what is trans airway? Can you figure it out by just looking at the word trans? Like if you're going to transport, trans airway, it's going across a distance. So what is the pressure at the beginning? What is the pressure at the end? That would be trans airway pressure. So the difference between the airway opening pressure and the alveolus. And then transpulmonary pressure is the pressure between the alveolar space and the pleural space. Not applied very often, so other than your reading in your textbook. So with the difference between letter A and letter C, what would that be called? Transairway pressure, from mouth opening to alveoli. What would it be called between letter C and letter D, between the alveolus and the pleural space? Transpulmonary pressure. All right, so I guess this would be good for index cards, just to write these down. On your index card, if you write an explanation, maybe you can also draw a picture and label each part of, if you guys are a better artist than me and you can draw this picture on your index card and just say this is the airway opening pressure, this is alveolar pressure, pleural pressure, just to get the practice in. Okay, apply your newly found knowledge. What pressure has to be the most negative to keep the lungs inflated so they don't collapse? Yeah, very good. Pleural pressure. We know that's true because if there's a blunt trauma or a stab wound where it goes from the atmosphere into the pleural space, and now the pleural space is the same as atmospheric pressure, we know that the lung collapses. So that's why the pleural space has to be the most negative to keep the lung open. What is the name of the pressure gradient between the mouth and the alveoli? Trans airway pressure. Good job. All right, now we talk about lung compliance. And lung compliance is a measure of the stiffness of the lungs or how well the lungs are able to expand. It tells you that high compliance indicates the lungs are easily inflated with very little pressure, and low compliance indicates that the lungs are stiff and it takes high pressure to ventilate the lungs. All right, so let me explain that a little bit more, because that's really important. This is like your understanding these principles. Once you understand them, then it gets you through the whole semester. All right, so when you put somebody on a ventilator and you push air into their lungs, pressure is going to build up. If they've been a smoker for many years and they have COPD, their lung tissue is real stretchy, like if you've ever had a balloon and you blow it up 3 and 4 times, it never goes back to its original shape, it kind of stays kind of stretched out. Same thing with COPD lungs, is they're very stretched out. Very easy to put air into those stretchy lungs. So you send a volume of air into COPD lungs and you're going to notice not much pressure builds up because those lungs are very compliant. They're very stretchy. It's very easy to get the air in. So that's what high compliance is. So do you want to write that example down in your notes so you can attach it to a picture in your mind?
Isn't it good to have high compliance or it's not good?
What's good is to have normal compliance. And the reason that it's not good to have highly stretchy lungs is because the air doesn't come back out very well. So we can put it in, and it takes a long time for all that air to come back out. So what are you going to write down? Example, COPD patient has stretchy lungs.
They can get air
Would
with
that
very
make
low
it
pressure,
easier?
but they can't get it out.
Right, so the air can go in with very low pressure.
The air can go in with very low pressure?
Yes.
Does that mean that it's harder for the air to come out?
Yeah, so because their airways are not supported by healthy tissue, when they try to exhale, they don't have the support of the airways, and the airways collapse on exhalation, and it's hard for the air to come back out.
Just like with the stretchy balloon, it's hard for the air to come out.
Yeah.
It makes all this noise.
Yes.
And that's why they use their accessory muscle, right?
Yes. Yeah, a COPD patient not on a ventilator, it's hard for them to exhale. They start using their abdominal muscles to get the air out. They use pursed lips to try to get the air out.
You said we have normal compliance, like we wouldn't be either of these.
Correct. All right, so somebody with low compliance, that happens with,
Asthma?
no,
Or restricted.
Obstruction?
with more of like a restrictive disease like ARDS, so pulmonary edema. I'm trying to think of some of the terms that you're familiar with, like pulmonary edema, when there's fluid in the interstitial space or fluid goes into the alveoli of the lungs, it makes the lungs really stiff. So when you try to push a volume of air into stiff lungs, it takes a lot of pressure to get that air into the lungs. And that's because the lungs are so stiff. So an example would be pulmonary edema. ARDS, have you heard of a mention of what ARDS is? I know you have it coming up in your disease class, but patients that have an acute injury, so they're in an automobile accident, and there's a lot of damage to the body, whether it's broken bones or whatever. Within 24 hours, it's possible that their lungs will become stiff. So what happens with a trauma to the body is there's a lot of inflammatory mediators released into the bloodstream, and it causes even the lungs to get involved if there was no damage to the chest at all. And the surfactant gets washed out, fluid goes into the alveoli. It's hard for these people to oxygenate. So usually like 24 hours after the car accident, or after they're getting a bad pneumonia, they'll be really short of breath. You'll notice that you have them on a cannula and now their O2 sats are low. You switch them to a mask, O2 sats are low. You've got them on a non-rebreather mask. It's really hard to oxygenate them. They're breathing really fast. You try some other things, eventually they end up intubated on the ventilator. And what was happening is the trauma to the body is causing pulmonary edema, it's washing out the surfactant, and it's making the lungs really stiff. So all of that describes ARDS. So pulmonary edema, stiff lungs, ARDS would be like the clue that you have stiff lungs. Janaya?
What about with atelectasis?
It doesn't make the lungs too stiff. All right. So if you have a patient with COPD, would you expect their lungs to be low compliant or high compliance? High compliance. And what about a patient in pulmonary edema? Low compliance.
Yvonne? Did you have a question?
Patients who are heavy smokers have lower lung compliance, or that doesn't really affect it?
High lung compliance.
Oh, okay. Oh,
Yeah, with the smokers, the supporting structures for the airways are destroyed. So you don't have that elasticity in cigarette smokers. When you lose that elasticity, the airways collapse when you try to exhale. But with the loss of that elasticity, it's easy to ventilate them. You can push the air in really easy, very little pressure builds up, but then there's a problem with their exhalation. There's a formula. So the volume that you put into the lungs, divide by the pressure that builds up, is going to give you your units for lung compliance. So that arrow before it, delta V, is pretty much the tidal volume. Delta P is the change in pressure. So here it explains it to us. VT, or tidal volume, is the volume of air going into the patient's lungs. PIP. When a volume of air goes into the patient's lungs, you will note that the system pressure builds during inspiration to a peak, and then it drops back down to baseline during exhalation. The highest pressure which is attained during inspiration is called the peak inspiratory pressure, or the peak airway pressure. So PIP is peak inspiratory pressure, peak airway pressure, or if you want to refer to it as PIP, you can do that. What you cannot do is call it PEEP. All right, so PIP, you can't say PEEP. And the reason why is after that, because there's another setting called PEEP, PEEP, which stands for positive end expiratory pressure. All right, I'll tell you something real quick about PEEP, but we have a slide coming up where you're going to write down more information. One thing that helps with oxygenation is at the end of exhalation, instead of exhaling all of your air, if you keep a little bit of air in your lungs, it improves oxygenation. So if you keep a little bit of air in your lungs, then you're keeping a little bit of positive pressure in your lungs, and then oxygenation will improve. So we can use the ventilator to not let go of all the patient's air, to kind of hold some air in their lungs and keep that positive pressure in there even at the end of exhalation, and then we'll notice their oxygenation will improve. So that's what PEEP is. So you don't have to write that because we'll come up to it in a bit. But you do need to know to subtract it in the formula. Let's see. All right, so it looks like our practice is coming up. All right, I'll go through these slides and then we'll practice with it. All right, when we're measuring compliance, there's two types. The first type is called dynamic compliance. It's going to be, what contributes to the compliance will not only be the stiffness of the alveoli and the lung parenchyma. Lung parenchyma is just lung tissue that's around the alveoli. So it includes the alveoli, the stiffness of the alveoli and lung parenchyma, but it also includes airway resistance. So let me draw a trachea. All right, here's two tracheas drawn on the board. Can you see it even though the lights are off?
Yeah.
All right, if you're going to push air through the two tracheas, which one do you think will take more pressure to push the air through? The one on the right. And why is that? Yeah, the radius is smaller, it's narrower. So the smaller the airway, the more pressure it's going to take to push air through that airway. So on your ventilator, when you get a pressure reading, and the pressure reading is high, it could be high because there's narrowed airways, or it could be high because your alveoli are stiff. You don't know which one. All right, so that's the first type of compliance we're talking about. Airway resistance is affected by the lumen of the airways. Lumen means the size of the opening. If you have a small endotracheal tube, you're going to have more resistance when you push the air in. Do you want to write that down? Like next to small endotracheal tube. Like small tube, more resistance, therefore more pressure to get the air in. So small endotracheal tube, small tube, more resistance, more pressure to push the air in. All right, the next one listed is bronchospasm, and that's when the smooth muscle around the airways tightens up. So somebody that has reactive airway disease like asthma, something can trigger their airways and those muscles tighten, and when the muscles tighten, it narrows the airway. So a narrow airway, again, it's going to take more pressure because there's more resistance. So does it follow that if you have secretions plugging up the airways, it's going to take more pressure to push the air in if you've got all the secretions in the airways and you've got to get the air past all those secretions? It'll take more pressure? Does that kind of go together? Okay. And then the last one, it says a very fast flow of air into the lungs will also increase pressure and affect the dynamic compliance. So when you're pushing air into the patient's lungs, that's a setting that you're going to be choosing on the ventilator. And if you push it in really fast, it's going to cause turbulence in the air, and it's automatically going to cause a lot of pressure to build up. So if you push the air in too fast, you're going to see that pressures are really high, just because you're pushing the air in too fast. All right, does that last bullet make sense to you? All of the above will cause an increased pressure when the volume is delivered to the lungs. Good so far? Okay, so the formula we talked about already. We put the tidal volume on top and the change in pressure on the bottom. We have a true-false mini quiz. Ready? Anything narrowing the airways or the endotracheal tube will cause an increase in pressure when volume is delivered to the lung. Is that true or is that false?
True.
It is true. More resistance, more pressure to get the air in. Next bullet, anything narrowing the airways or the endotracheal tube will cause an increase in dynamic compliance. Yeah, that's false because as the pressure goes up, the compliance value will go down. Do you need to write the explanation next to it? All right, so circle false. And just write high pressure will give a low compliance value. And then the third one, airway resistance is the only factor that contributes to dynamic compliance. True or false?
False.
That's false. What else contributes to the dynamic compliance? Pressure? Okay, so airway resistance is one. What about the alveoli, the stiffness of the alveoli? Yeah, that contributes to it also. All right, so dynamic compliance, you push the air into the lung, you see pressure building up. And when you see pressure building up, you don't know if it's because your airways have increased resistance Or is it because your alveoli are stiff? You don't know. You just see that your pressures are up. Well, with static compliance, a static compliance reading, you're able to see only the alveoli and the lung parenchyma. So how do you do that? You stop the flow of air in the patient's lungs. All right, let me read this. So static compliance measures the stiffness of the alveoli and the lung parenchyma only. So no airway resistance in this one, just the stiffness of the alveoli. This is measured when the flow of air into the patient's lungs is stopped. So there's a button on the ventilator that you push to get this reading, and it's called plateau pressure. When you push plateau pressure, or inspiratory hold is another name for it, it stops the airflow and holds it still. And when you hold the airflow still, the pressure reading that you see is telling you what the pressure is in the alveoli. So the plateau pressure button, that inspiratory hold button, you press it and it stops the flow of air, and the pressure that you see is the pressure in the alveoli.
It's plateau pressure. What else you said it was called?
Inspiratory hold. All right, so when you plug that into the equation, you put your tidal volume on top, and on the bottom, you write down the plateau pressure. You subtract the PEEP from the plateau pressure. So all of these numbers are given to you. You just have to know how to plug them into the formula. Oh, we have more true-false here. Anything narrowing the airways or the endotracheal tube will cause a decrease in the static compliance. Is this true or false? It's false. Because the static compliance has nothing to do with the airways. The static compliance is only when we pause the flow of air and look at the pressure in the alveoli. Fluid in the lung parenchyma or stiff alveoli will cause decreased lung compliance. Is this true or false?
True.
It's true. So when you have stiff lungs, you're going to have a low number for your compliance reading. An increase in the plateau pressure will indicate a decrease in static compliance. So higher pressure, will that make the... So if you have a bigger number down here, is that going to result in a smaller number when you divide?